Good morning, everyone. We have the last presentation of the academic year today, and we are excited to have Dr. Harish Seethapathy from Boston, from Harvard Medical School, presenting to us on correction rates in hyponatremia. You may remember the NEGM evidence paper that we discussed a few months ago. That was led by Harish. So Dr. Seethapathy is a clinician educator in the Division of Nephrology at Mass General, as well as an assistant professor at Harvard Medical School. His research interests span hyponatremia, glomerular disease, and onconephrology. He's in fact the program director for the GlomCon Fellowship that some of you have done and some of you may be interested in doing. He was also the co-chair of the education committee for the American Society of Onconephrology, and he's the director of education for the Brigham and Women's Health and Mass General Nephrology Fellowship Program. So welcome, Harish.
Thank you so much, Swap. Can you just confirm that you can see my slides?
Yeah, we can see your slides.
Okay, awesome. Thanks for the warm welcome. And today I'm going to be presenting on correction rates in hyponatremia. With the sort of release of the new season of the new Game of Thrones series, House of the Dragon, I think I name my talk Fire and Ice. And what we're really going to do is kind of talk about the history of this controversy rather than the exact sort of practice guidelines or things like that to come up with why we actually do the things we do. But before that, I don't really have any disclosures. So what is this talk really about? It's a no-holds-barred, detailed look at the evidence behind correction rates in severe hyponatremia, and really to ask the question, how did we get here, and why do we practice the way we do? I'm going to convey to you the evidence that shaped this conversation, and I'm going to present to you the data, mostly in the author's own words, the scientists who came up with the data. I know that expert opinion has shaped this topic quite a bit, and we can't escape that. We have to talk about the escape opinion, but I'm going to try not to add my own biases and my own anecdotes to this conversation, and I'm going to give you the evidence in people's own words when they presented it initially. So unlike many areas of nephrology, when you take any sort of glomerular disease or any other topic, there's like 30, 40, 50 people shaping the discourse, right? There's a lot of debates, there's a lot of thinking about the data, whereas with hyponatremia, there's really only two sides, and there are two very small groups and people who align with those two sides. And these two sides really shape the discourse of this. And in the spirit of House of the Dragon, I'm going to name these two sides House of Stark, standing for ice or slow correction, and House of Targaryen, standing for fire or fast correction. And these are two very polarized sides. But they don't just stand for slow or fast corrections. I want to give you what they actually think correction rate should be. So House of Stark feels that everyone should be corrected slowly, around 4 to 8 per 24 hours, as there is high risk of correcting faster and there is no benefit to doing that. House of Targaryen, on the other side, they think that there is no risk to fast correction, but with a caveat, as long as the sodium is not corrected to mildly or normonatremia. Like as long as the sodium is kept to under 130, you can correct as fast as you want. But of course, as one would expect, the truth is somewhere in between, and perhaps a lot of it is unknown. So we're really going to talk about the history of how we came about, how these two sides, sort of aligned with each other. We have to move through the decades. Back in 1959, that's when the origins of CPM were first sort of described. It took almost 20 years before people realized that sodium had anything to do with CPM. And another 10 years before they thought that correction played a role. And this is also the time that CPM kind of like fell to the background and ODS, or osmotic demyelination syndrome, came to the forefront because it was felt that sodium correction was the chief risk factor for this syndrome called CPM. And then there was a lot of debates. Of course there was, right? We nephrologists love to debate all the time. There's a lot of debate on sodium, what the correction rate should be, whether CPM is just a sodium disorder, so on and so forth. And then for the next 20, 25 years, it's hardly any data produced. Most of this was just debate, sort of like, trials and tribulations in the public arena, at conferences, but there was not a whole lot of data produced between 1990 and I would say 2014. So there was some important data in the field, such as the use of DDAVP, for example. And of course, now in the last year, we've had more new data coming out now that we can leverage these large databases to sort of tell us exactly what has been happening over the many, many years that we've come to debate this topic. So is it really a controversy, or are we starting to understand a little bit more? Oh, let's go back. When did this story first begin? I'm going to take you back to 1959. Just to give you just to anchor this talk, when we move through the years, I'll give you some events that happened in those years. So 1959 was the time that Fidel Castro became the prime minister of Cuba. He was only 33 at that time. And remember, he was in power from like 1959 to 2008, a very long time. It was also the time in pop culture where the first 70mm film came out. The visuals were so vibrant and people were praising this new movie, Sleeping Beauty by Disney. At the same time, in the hospital where I practiced, there was this group of neurologists and neuropathologists who thought they'd come upon a disease that had never been described. So they called it a hitherto undescribed disease occurring in alcoholic and malnourished patients. So Adams et al. Described 4 patients, 3 of whom had alcoholism and 1 of whom was malnourished. They described a syndrome where they noticed rapidly evolving quadriplegia and then some pseudobulbar palsy, essentially weakness of the face and tongue, inability to speak, swallow, and eventually the paralysis led to coma and even death in 1 or 2 patients. When they actually looked at the autopsy of the brain, it was somewhat striking in that the nerve cells and the axis cylinders were completely preserved. What they noticed was the myelin sheath, especially in the pons, was completely gone. It started at the center, and then it just completely spread to the periphery, and there was a sharply demarcated symmetric demyelination that was noticed in the pons. Their conclusion, after comparing it to many other diseases, such as Wernicke's and a bunch of other diseases that they thought could affect the brain, they felt that this was not vascular, this was not nutritional, this was not traumatic. So there was some distinct pathology that was going on, which may be connected to one of these, but had never been described before. And that's what they call a central pontine myelinolysis. Now, over the coming years after 1959, of course, once people saw one case, they started to describe a variety of other cases, some associated with infection, some with toxins, some with ischemia or stroke, some with very many vitamin deficiencies, some with liver disease, and even osmolar changes. Look at this beautiful case where the glucose went up as high as 1,000 and came back down very quickly. As you can see, the sodium was almost normal, 130 to 150, hyponatremic if any, but this patient had very severe CPM. So a variety of risk factors were put forth as occurring in many different patients, but as the case reports came in and in, you started noticing a pattern. Many of these patients had severe alcoholism, and a lot of these patients were malnourished. For example, they could have just bad alcoholism or TB or some sort of cancer, whatever it might be. That malnourishment was very common in these patients. Now, Rosman, an author, again, and in Boston, he had a pediatric patient who had CPM. And that patient had leukemia. And he was wondering, now it's not just an adult disease, maybe it can even occur in kids. What actually causes this? So he looked back at the literature, even at that time, back in 1966, and started to see if there was a pattern. And he noticed the first, like alcoholism and malnutrition, as one of the most common, two of the most common risk factors. But he also started to notice that a lot of these patients had dehydration. So he looked at the incidence of dehydration and electrolyte imbalance in 34 cases of CPM. And he said, yes, there were certain cases, maybe half of them had dehydration or electrolyte imbalance or both, but a lot of them had neither electrolyte imbalance nor dehydration. Now, we don't know the exact definitions for these. What is dehydration, for example, or what electrolytes are we specifically talking about? We don't know that yet. Now we move on to 1967. 1967 was a very sort of torrid year, a year of civil unrest. The Civil Rights Act was just passed in 1964, but of course there was a lot of trouble in implementing it. And so there was race riots in over 150 cities and towns in America. And it was called The Long Hot Summer of 1967. There was even a movie about it, but it was one of the first things that came out after the Civil Rights Act that led to more equality and more conversations about racial inequalities. So, nephrologists, we don't like to focus on that. So we go back to CPM and to Iowa City, where Dr. McCormick and his colleagues again looked at 69 patients with CPM. Since we're talking about 1967 and a period of really bad racial inequality, you can see how the medical literature was worded when they describe the racial classification of these patients. So I'll let you take a read for that. But back to our patient cohort, 69 patients with CPM. Now they took looking at every case report, every case series that had been published about CPM, and this is what they noticed: the same thing that Rosman had noticed a year back, which was that 50% of the patients were noted to have severe alcoholism. 77% of patients were very malnourished, and 20% of patients had neurological disease. Could be MS, could be stroke, could be something else where the cognition and other neurological abnormalities existed. And also curiously noted that severe electrolyte abnormalities were present in 33%. Now, if you look at McCormick's list, and he gives a very extensive list, if you look at the publication, 5-6 pages are just case summaries of all these patients. A lot of these electrolytes that he's talking about is actually hypokalemia, and some of which may be hyponatremia, which I take, is denoted as dehydration in some of these patients, but it could be anything. Bad, low potassium, low phosphate, low sodium, but severe electrolyte abnormalities are present, at least as far as we know, in 33% of the patients. Now, I kind of looked to see if during this period, BMPs were very common, and for the most part, they were. You did get a CBC and a BMP in most patients by this time, so it wasn't like we never measured those in some of these patients. So this is what he said when he looked at all of these cases. He said, the wide spectrum of disorders from which patients with CPM have died suggests the possibility that there may not be one, but several causes, the end result being the pontine myelinolytic lesion we know as central pontine myelinolysis. So he felt really that there was a wide spectrum of disorders and not one thing that could lead to this disease. We jump ahead 10 years because this is when things really changed and CPM, or as we might call it ODS later, started to take a turn. We really started to notice the sodium. But what else happened in 1977? We had the worst aviation disaster where a Pan Am flight and a KLM flight collided in Tenerife when one of them was not clear for takeoff. This, of course, led to a variety of cockpit procedures to make sure that everybody was using standard language when taking off, landing, so on and so forth. We also had Apple II released, which was the world's first personal computer. I think it sold for around $800 when it first came out, and then became extremely popular. It was also the year where Rocky won the Academy Award, a widely popular film at that time, and even now I'd say. So 1977, Burkhardt and colleagues are again studying CPM. They're like, hey, let's see if we've now known that alcoholism and malnourishment are real risk factors, but is sodium a real risk factor? I want to really know. So they looked at 46 patients with CPM who had electrolyte data available, and they found that severe hyponatremia, or a sodium less than 120, was present in around 25% of patients. And when they looked at people with normal sodium, even 13% of these patients had completely normal sodium. So 75% of patients had a sodium that was, 120 or higher. There's also, I think, around 8 to 9 animal studies that came out in these 10 years, around 1980 to 1987. All of these studies were somewhat similar. You subjected the animals and created hyponatremia by giving them a lot of water and vasopressins, around 2 to 6 days of hyponatremia. And then you tried to normalize the sodium very quickly. And then you did an autopsy and saw if there were demyelinating lesions. Now, it was pretty clear that the rates of demyelination was higher in the animals who had corrected fast, or you chose to correct fast, rather than the animals who were hyponatremic persistently, or those animals who kind of like self-corrected very slowly. So it was thought that perhaps you could replicate this experiment in animals, rabbits, rats, and even there was even a dog experiment, where they were able to sort of demonstrate this. But the lesions were not exactly similar to what you see in humans. In these animals, the lesions were in a variety of places. They could have been in the pons, extra pons, cerebrum, cerebellum. It was just widespread in some of these animals. It wasn't really clear if there was an exact pattern in many of these experiments. It was also not clear if the demyelination itself was just due to fast correction or was it due to overcorrection? Because a lot of them just corrected to like 135 or higher, and whether that's the cause or whether it was the rate of correction that got them there. Because some of the experts at this time said that perhaps we should be correcting to only 130 or 125 to 130, and perhaps if you leave it there, despite how fast you correct, maybe the demyelinating lesions wouldn't be there. But then, it was hard to do these experiments because it's not exactly easy to control the rate of correction by itself. It's easy to correct a normalcy, but it's very hard to correct to a particular level of sodium. So anyway, once the animal experiments were done, you kind of had to see how it translated to humans. So we go to 1987. This was a pivotal year for many reasons, and we're going to talk about why. Here you have the Reagan speech. He gave one of the most famous speeches of the Cold War, where he said, "Mr. Gorbachev, dead on the wall." And I thought this was an iconic speech, but apparently at that time, nobody cared. And it only became an iconic speech after the wall came down because it was literally toned down. And importantly for many of you folks, the first Starbucks opened in Canada. So a real milestone there. And of course, when the Starbucks opened, people would talk to nephrologists who walk into Starbucks were probably talking about this paper. But before I talk about the seminal 1987 paper by Richard Stearns, I do want to talk about one other paper that he published along with a colleague in West Virginia, where they looked at 8 patients with neurological sequelae after correction of hyponatremia. They felt that they had a small case series of patients who had neurological disease after the correction of hyponatremia, and they wanted to illustrate that fast correction was the main factor that led to these lesions. It is important to note that this was the very first study where we sort of moved away from imaging or autopsy and plainly depended on sort of the clinical judgment of the clinician. So they said they had 8 patients who had neurological sequelae after sodium correction, and only 3 out of those 8 patients had imaging or autopsy findings that were positive for CPM. The others, they said, were probably CPM, depending on the neurological findings, but they didn't have any confirmatory findings by imaging or autopsy. So these were the 8 patients that they presented. As you can see, they also went and looked at all the literature, and they basically said, hey, if you look in the literature, a lot of patients who corrected fast had CPM or death, whereas a lot of patients who did not correct fast, and by fast, they meant less than 12 millimole per liter per day, had uncomplicated or complete recovery without any issues. This was also sort of the harbinger for like the future papers, right? Every paper that came out by Brunner in 1990 or Tano in 1994, Ellis in 1995, a lot of these retrospective studies now use sort of clinical evaluation by a neurologist, nephrologist, or whatever it might be to look at the incidence of ODS. And similar to Stearns' first paper, where the incidence of ODS was around 17%, these papers also found a very high rate of ODS, which was around 11 to 24%, right? And very few of these, if you look at the last column, had actual documented CPM by imaging or autopsy. So these were all what we call as clinical osmotic demyelination syndrome patients. Now, a year later, 1987, his seminal paper comes out. This was a big cohort of unselected patients from Rochester, New York, and they look at 62 patients with a sodium of less than or equal to 110 and look at what happened neurologically to these patients. And they said that 7 patients had ODS, right? And they sort of describe these 7 patients, and they say the rate of ODS is extremely high if you correct more than 0.55 milliequivalents per liter per hour, which roughly translates to a correction factor of around 12 in the first 24 hours. So the ODS incidence, as I said, was extremely high. And 2 out of these 7 patients, I should note, had severe mortality or morbidity, like coma, death, complete neurological, like no neurological prognosis was very poor. Whereas there was 3 or 4 of these patients who had ultimately had good recovery, which is not really noted in the future papers, but it's important to know that even in the initial papers, the rate of neurological recovery was not low. It wasn't a death sentence, for example. It is a disease of high mortality and morbidity in some patients, but in others, they were able to recover. We can never really differentiate between who was able to recover versus who was not because we don't have the details from those cases. So, 2 important things came to be true, right? At this point in time, ODS, now it's, we've completely moved away from CPM. We really think about sodium as a centerpiece of causing CPM, and we call it ODS, is no longer a radiological or autopsy-proven disease. It also established sodium as a centerpiece risk factor for ODS, and again, the first correction rate as the first limit was established. This was around 12. They said maybe 15 is okay, but 12 seems like safe, right? This was 1987. Now, I think this is historically, I think for a nerdy me and for the nerds in the audience, I think this is like super fun to watch. One of the reasons why they said sodium correction was the centerpiece risk factor was this chi-square table, like this, unadjusted analysis where they looked at like risk factors like alcoholism, symptoms, and the rate of correction. And they said the only thing that was significant was the rate of correction. And they made a very important note in the conclusion of the paper, which came to define how we look at correction rates. The authors said, thus, the neurological complications in our patients were probably the result of well-intentioned efforts to correct a relatively benign condition rapidly. That is, we suggest that osmotic demyelination syndrome is an iatrogenic disease. Now, this was controversial, yes, but it also had some unintended consequences, which is that, it became a big point of contention in many medical legal cases in the future. Okay, was that the only paper? No, there was another paper in 1987, which didn't get as much attention. And this was by the Targaryen group, where they looked at, they said, hey, yeah, it looks like these CPM lesions are true, but what actually causes them? There's a lot of confusion. Do we actually name the CPM? Why are we calling it ODS? And so they sort of raised a lot of questions and decided to do their own study, which was published in NEJM. So they looked at 3 groups. The first group was the patients with a sodium less than 120 and had some imaging. These are not patients with CPM, just anybody with less than 120. They wanted to see what happened with correction and what happened in the imaging. The group 2 was CT or autopsy proven CPM. And group 3 was CPM cases in the literature looking at what their correction rates should have been, kind of similar to what the last paper did. So what did they find? Among the patients who were referred to them, remember, this is their center, they said that with a mean correction 24-hour correction rate of 20, there was no CPM in the 33 patients that they saw who had imaging findings. And in group 2, where they looked at CPM regardless of whether people had hyponatremia or not, they said 4 of those cases had almost normal sodium, and among the rest 8, the mean correction rate was around 20. And also they noted that in the group 2, those with CPM, 10 of those patients were comatose even before therapy initiation, meaning like therapy had no role to play in the onset of CPM. And when they looked at literature cases, they said most of the time the rate of correction was around 15 to 20 in patients who had sodium data available and had CPM that was attributed to sodium correction, or could have been. So they said that rapid correction to mildly hyponatremic levels, and they're talking about, I think, around 125 to 130, is not associated with either clinical or anatomic evidence of neurological damage. So a lot of debates after this, of course. I highly recommend this paper. I think it's a bunch of nephrologists really like geeking out about physiology, which I love to read. And Thomas Pearl does an amazing job, keeping the discussion going. But essentially at that time, it was like damned if we do and damned if we don't, because there was enough data to suggest that, severe hyponatremia could lead to bad outcomes, and obviously correcting it fast could lead to bad outcomes. So the actual suggestion in this paper and in this controversy and some of the editorials written at this time was, hey, just don't go more than 15 to 20. 15 to 20 seems like anything over that seems really high, and don't do that. Just like correct like maybe like 15 and then see what happens and then decide if you want to go further. That was sort of the general consensus at that time. This was 1990 that I'm talking about. Now, a shout out to the one prospective study that was done. It was a very small study, but Brunner looked at 13 patients with hyponatremia, and they didn't influence the correction rates, but they imaged these people, meaning their average correction rate was around 25, so pretty high. But they imaged all these folks with serial MRIs at like 1 week, 2 weeks, 4 weeks, 6 weeks, 12 weeks, how many ever MRIs they could do in these patients. And 3 of those patients had findings of CPM on imaging. One of them had hardly any symptoms, and all 3, by the end of around 12 weeks or so, had sort of recovered neurologically, even though the average correction rate was around 25. So now we go to 1992. This is kind of the period at which the controversy really starts to like stir up, right? So what happened in 1992? Bill Clinton becomes president. We have this iconic movie from Spike Lee and Denzel Washington called Malcolm X. And Mae Jemison becomes the first African-American woman in space, a huge milestone at that time. Getting back to our sodium and our battle and the controversy, the Targaryen group publishes a paper where they look at 65 patients with post-operative encephalopathy due to hyponatremia. They say it's extremely common after surgery to get hyponatremia and be encephalopathic, and they note that there's a very high risk of death or permanent brain damage just from being hyponatremic. They also note, I don't know if this makes any sense, is that out of the 34, 33 were women. So women were much more at much higher risk of getting hyponatremic encephalopathy. That part makes sense because women have different body constitutions and are at a higher risk for like hyponatremia correction and so on and so forth. But they also know that 25 of those women were menstruant females. I'm not really quite sure what that meant. But anyway, the cause of death in these patients was respiratory arrest. So they're saying that, hey, if you develop hyponatremia post-surgery, and especially if you're a female, your risk of death is very high, so you need to be treated, right? They had published other similar papers somewhat like showing this phenomenon, and it was commonly accepted at that time that if you're a female undergoing surgery, your risk of hyponatremia is high, but if you do get hyponatremia, your risk of death is even higher. And through the 1990s, they debated these topics about like who's at risk, how fast you correct, and who should be corrected. And then came this 1999 paper where the Targaryen group again published a group of patients with post-operative hyponatremia of less than 130. And they said these are all patients referred to them. And they looked at 3 groups. They divided them into 3 groups based on their treatments. One group received early sodium chloride. One group received late sodium chloride. And by early and late, they meant early meaning before the onset of respiratory insufficiency. Remember, that's what they said they were at high risk at. And late meaning after the onset of respiratory insufficiency. This they purely said was due to the timing of the referral, meaning if they were referred before the onset of respiratory insufficiency, we put them in the early group, treated them. If they came in after respiratory insufficiency, we put them in the late group and treated them. And then there was a bunch of patients who they just like did fluid restriction. And the outcome of this study was that rapid correction saves you from respiratory arrest or hypoxic events, especially group 1. And that slow correction, like if you give it late or if you just do fluid restriction, they're a high risk of neurological mortality and death. Now, this again became very controversial and led to a war of words. So I'm not going to make any of this up. This is in the public domain. This is a letter to the editor that was published between the 2 groups. So I'm going to read it out exactly as it was published. So the first letter to the editor from the House of Stark was that in the past 15 years, Dr. Targaryen and Dr. Targaryen's colleague have reported more than 200 patients referred to them after a respiratory arrest or hypoxic event. The authors apparently played no role in the management of these cases. During the same period, the authors directed the treatment of 49 patients with symptomatic hyponatremia. No patient developed a respiratory arrest or hypoxic event, and all recovered. Apparently, to be treated for hyponatremia by the authors guarantees protection from hypoxia before treatment and brain damage afterward. To be treated by anyone else risks almost certain respiratory arrest, death, or disability. The invariable occurrence of pre-treatment respiratory arrest and mechanical ventilation and the high incidence of fatal cerebral edema in patients purported to have chronic hyponatremia fly in the face of 75 years of accumulated physiologic knowledge and clinical experience, some of which were contributed by the Targaryens themselves. So basically saying it's almost inconceivable that you would have such a high rate of respiratory arrest and cerebral edema with hyponatremia when we see so many of those patients who don't get those symptoms, right? And of course, there's some snark thrown in. So this was a response by the Targaryens, which was like, Dr. Stark's emotionally charged comments may have limited his ability to critically review the issue of the therapy of hyponatremic encephalopathy. Dr. Stark is a longtime advocate of therapeutic nihilism in the management of hyponatremic patients. He appears to suggest that only patients treated under our guidance can have successful outcomes, whereas to be treated by anyone else risks cerebral edema, respiratory arrest, and death. Apparently, Dr. Stark has either neglected to review the literature or selectively avoided all evidence to the contrary. Dr. Stark's contention concerning the rate of correction remains unsupported by data. So I have to say that at this time, both sides felt that if practice didn't adhere to what their opinion was, that they would be causing serious damage to patients. One side felt that hyponatremia needed to be treated promptly to mildly hyponatremic levels and corrected fast, whereas the other side felt that there was no benefit to doing that and that you run the real risk of ODS, which they had successfully shown in some of their data. The polarity of these comments, I think, really made it such that most folks needed to align on one side or the other, and there's almost no conversation in between that happened when Thomas Bird initially started the conversation back in 1990. So after 10 years, the conversation had completely evolved, and there was just basically two sides. And this was reflected in the way that we practice, because defensive medicine is much easier to practice than is, like really going in and jumping in and doing stuff, right? And you might be labeled a cowboy for doing that. As you can see, back in 1983, this is data from our own study from 2 academic centers, the average rate of correction was like greater than 12. This fluctuated over the years, but whichever way you see it, there was a definite difference in the correction rate, pre-1985 to the practice nowadays. And I would say that it's even kind of lower now. If you look at the data post 2018, it's around 7 is the average correction rate for patients with severe hyponatremia who get admitted to the hospital. So, there was debates, there was communications, and there was a definite trend and in sort of the clinical practice. And correcting hyponatremia quickly sort of went out of practice. It became not the thing to do, and slowly, slow correction took center stage, and that's how we sort of practice medicine in the coming years. And the guidelines came out nearly 25 years later. And when I say guidelines, I say that in a very loose, the guidelines is a very loose term for it, because the USA guidelines was essentially by 7 physicians, all of them are nephrologists. The European guidelines were a little bit more robust. It involved the ERA, the European Society of Endocrinology, and intensive care. So it was much more of a collaboration in the way in which they came up with the guidelines, but they're very similar. So the USA guidelines say your target rate is 4 to 8 for low risk and 4 to 6 for high risk. And high risk means people with alcoholism, hypokalemia, malnourishment, but this kind of got relegated to the footnote. And the limit being 10 for low risk and 8 for high risk. And they really recommend 8 in some of the subsequent papers that have been written too. Whereas Europe kind of says that the limit is 10. They don't necessarily give a target of how much you need to fix. They just say, hey, don't go above 10 if you can. Both the guidelines or the papers do recommend some relowering when limits are exceeded. They don't necessarily say in whom that you need to do this. The USA kind of gives a loose guideline on like, hey, it's better to do it especially in high-risk patients, but both have to be relowered if you exceed the limits that have been recommended. And as you can see, all these papers and the data that I presented, that's kind of, and the conversations that ensued over the 20 years before these guidelines are what led to these guidelines in the first place. In practice, though, this is what happened, right? I wouldn't call it nihilism. I think that's a very strong word, but I think there was a certain amount of hesitancy in patients who presented with severe hyponatremia. I think all patients, regardless of risk, were kind of put on the same protocol. There was a lot of hesitancy and delay in the use of 3% saline. For example, in our study, more than 3,000 patients, the use of hypertonic saline in the first 24 hours was around 12%. That seems really low for a population who comes in with such low sodium. And there was definitely a delay in the correction, a lot of ICU transfers because it was felt that people were at very high risk neurologically and needed to be monitored frequently. And of course, when you correct it slowly and and the delays happen, it does lead to longer hospital stays, as we saw in our study. And of course, there was a huge sort of burden on litigation and I totally underestimated how much there was, but there's been plenty of cases which have been argued where, hey, the rate of correction is 11, and that's what caused the ODS versus 6, and that's what caused, didn't cause the ODS, or whatever it might be. And there's a lot of like medical legal cases that happen because of these guidelines and the way that we practice medicine. So finally, I'll come to 2023, 2024, and the new papers. And I have to say, when these new papers came out, that fast correction folks, or the people who support fast correction, suddenly felt like, hey, there's so much evidence to support correcting them fast. However, really caution as to like how to interpret the evidence and what these studies are designed to study. So let's look at them very briefly. And I have these two beautiful visual abstracts from Neph Madness. So I don't have to create my own, by Michelle Lim and Brian Rifkin. So I'm going to go with the first study that came out of the Canadian group, which was 5 hospitals, more than almost 23,000 admissions. And they looked at ODS. They also looked at, kind of like how many patients correct fast. Around 20% of patients correct very fast, which means more than 8 was their sort of limit or number that they used to define fast correction. And they found only 12 patients out of these 23,000 admissions who had ODS. And 7 out of those 12 patients did not have rapid correction of sodium. Now, this is where I think there was a lot of criticism on the study because it included most of those patients who had a sodium of less than 130, and they said, hey, most of the risk comes from patients who have sodium of less than 120. But I'll push back immediately and tell you that that's not what the literature supports. The literature says that there's ODS is across the spectrum of sodium. Yes, there may be a slightly higher risk with lower sodium, but there's been plenty of cases with the sodium being 120 to 130 that I would not discount those patients who come in with the sodium between 120 and 130. There was, of course, other discussions and we'll study, but again, like many of the first studies 40, 50 years ago, the associated risk factors for ODS in this study was like hypokalemia, alcohol use, liver disease, malnutrition, cancer. And then came our study, which was kind of similar, but looked at patients, 3,000 to almost 3,300 patients with a sodium of less than 120, so the so-called highest risk patients. And we divided them into 3 groups, less than 6 being slow, 6 to 10 being sort of medium or optimal, and greater than 10 being fast. And that I have to say, in this study, as well as the Macmillan study or other studies that have been there, people correct fast regardless of what we do, meaning the rates of fast correction is anywhere between 40 and 70% in most of these studies, irrespective of the way that we practice this. Meaning no matter how much or how hard we try not to raise the sodium, no matter, even if we don't start hypertonic saline, even if we do nothing, many of the time the sodium rises pretty quickly. And in our own study, we found 7 patients with CPM, and 5 of the 7 had CPM, despite the initial correction rate being less than or equal to 8. And 6 of the 7 patients had alcohol use disorder, malnutrition, hypokalemia, hypophosphatemia, sort of the risk factors that you would traditionally see. I do think hypokalemia, hypophosphatemia definitely surrogates for severe alcoholism or severe malnutrition. We also studied mortality, which has never been looked in that much detail. We did find that, if you correct very slowly, for example, less than 6, you're definitely you're definitely at twice the risk of dying in hospital and at 30 days compared to folks who correct greater than 10. Of course, we adjusted this in 15 different ways. We did subgroup analysis, but I totally understand the criticism and the limitation that you can never fully correct the severity of disease, and that may be a big factor in accounting for the mortality difference. Also, honorable mention to the George study, which came out a few years before these 2 studies, which also looked at the risk factors for demyelination in patients with a sodium less than 120. Their cutoff was 8, and 7 of their patients had rapid correction, which is more than 8, but 2 or 3 of them, I think, corrected at like 9 and 10, so not a big difference from the cutoff. But they did show that, there was more ODS with like faster correction. But importantly, they also described these patients, which Macmillan couldn't do because of privacy reasons. And when you look at the patients in the cohort from George and the patients in our own cohort in these 20, 25 years from like these, 7 hospitals in Geisinger and 2 major academic centers in Boston, these 16 cases of ODS, the neurological outcome was starkly different to what was there before. We had, almost no deaths, and we had, I think, maybe 1 patient who did not recover total out of everybody. Pretty much everybody had partial or full recovery, and there was 1 or 2 patients who were lost to follow-up, but pretty much the prognosis was uniformly pretty good, I would say. And of course, you have all these other case reports, which we never give somewhat importance to, is that normal correction of sodium or within the recommended limits, you still get CPM, meaning no matter what you do, people correct fast. And even if you somehow manage to achieve the target rate of correction, you do still get a lot of CPM at these optimal correction rates at like less than 8. And I was looking at this NEJM clinical images in medicine image where they looked at CPM in 2016. They put this like striking image of like demyelination in the pons. And this patient was a 35-year-old male who had a history of severe alcoholism, who had corrected by an average of 3 milliequivalents per day in the coming days before, this patient developed CPM. So sometimes, no matter what you do, the risk is very high in certain patients. And another important study that I want to note, this was again in Boston, and really looked back and kind of went through the initial thinking behind osmotic demyelination syndrome and CPM, is that there are risk factors that are outside just sodium, because we've been really focusing on sodium for more than 30 years. And so I had to go back to the 50s and 60s to kind of see what are the risk factors are there and to really delineate them. So we verified this because we actually looked at this before this paper was published, and because we did not want to miss any CPM cases. There were actually around 50 cases of CPM or ODS in the 20 to 25-year time period of our own study, if you take CPM as that only proven by imaging or autopsy. So if you had that, you had these cases. The majority of these cases were in patients with a sodium greater than 130. So 75% of these patients had a sodium greater than 130. 57% had alcoholism and malnutrition as the 2 major risk factors. It is also important to note that 60% of patients with CPM, I'm not talking about ODS here, despite what the title of this paper says, made a full recovery. And only 16% died, and this was due to a variety of reasons, such as liver failure, kidney failure, cancer, immunosuppression, et cetera, none of which were like really completely related to ODS itself. So I've given you a lot of reasons as to like why there are other risk factors, but why do these other risk factors actually cause CPM? Meaning sodium, we kind of get it. We kind of get why it does it. If you raise the sodium, the water moves out of the brain, and so you get shrinkage and demyelination. That kind of makes sense. But what puts these patients with alcoholism, malnutrition, and normal sodium at risk for like pontine myelinolysis? And I think the biggest thing, and this is why I think it's a hard call for anybody to convince me that we can completely prevent CPM by just going slow, is that this paper for an evidence of apoptosis in CPM, where they looked at apoptotic markers in CPM, and they found that they were all very raised. And the hypothesis is that, when you have chronic hyponatremia, your brain tries to extrude all the organic osmolytes it has to prevent all the water from coming into the brain and causing cerebral edema. So when you raise the sodium, the opposite happens. A lot of water needs to move out of the brain because you're raising the sodium. But to protect against that, the glial cells or the brain cells need to like import back some of these electrolytes and osmolytes. And one of the main ways to do that is a sodium potassium ATPase pump. And the more effectively and efficiently they can like import back the osmolytes, the less they're prone to shrinking. But the problem is this is a very energy dependent process. And when these energy starved neurons are trying to do this, they release a lot of glutamate and initiate the apoptotic process. Also, when the mitochondria works at such high workloads, it produces a lot of free radicals, which can again damage and cause quick death and thereby causing CPM. So, the controversy right now when we talk about these things is we talk about the methodology of these new studies. I would sort of caution you and say that if you look at the old studies that I've shown you, I think, it's night and day when it comes to methodology. Of course, there's no RCTs. The biggest problem, leave even out the ethical complications of doing a fast correction versus slow correction RCT. But the biggest problem is, as I said, many of these patients correct fast, no matter what kind of protocol you put them in. So it's very hard to like get pure separation of like correction rates in these RCTs. And not that any RCT could be done at these kind of like, nuanced correction limits of like 6 to 8, 8 to 10, 10 to 12. Sure, we can do something that's like less than 10 and greater than 20, but of course, we don't want to do greater than 20. And we do think there's a real risk of like CPM if we start to practice that way. There's been proposed multi-center chart review and consensus statements or papers by the Stark group. I have to say it's not a diverse group. It's, they have had the same thinking for, the 30 years, as does the Targaryen group. So I'm not discounting that, but it's very hard. You only want to see what you want to see, right? So if you have a story in mind, you can only see that. I wish some independent investigators come in and actually, do these studies. And of course, in the era of epic charts, I always say like, if you look at 10 of my charts, maybe 10 of them have the wrong, 9 of them have the wrong exams noted, even though we try to be really, methodological and try to be really strict about what we, write down. In busy days, you don't know what's in the exam. And when you talk about the new evidence, I would say that the new data really questions established practice, and it is designed to raise questions, but not provide the answers. It doesn't really tell you what will happen if you just keep going fast. All it tells you is that just going slow is not the answer for everybody, and you really need to sort of distinguish who you should correct very slowly versus, be slightly loose and, almost be humble and understand that sometimes it doesn't always go according to how you want. So I am once again asking us to look at all of the evidence, not just the new papers, not just the old papers, but to put them in the context of like how we practice. So this is sort of the rough sort of timeline of the history of like how these guidelines came into place and how we practice. I will sort of, end with my own thoughts, meaning I think that sometimes I have to commit to something and I will tell you what my practice is because I keep getting asked like, what's my correction rate? Because I don't really have one. So this is what I think. I think that CPM or ODS, I think if it's radiological CPM, I think it's a black and white diagnosis. Now, clinical ODS doesn't really have a clear definition, and I'm not even sure if it's a severe disease versus not. And my suspicion is a lot of the recovery that we see, and a lot of people who do really well have clinical ODS and don't really, have like radiological signs because perhaps it's less severe. And the incidence is extremely low. If you just count radiological CPM, I think it's extremely low, 0.1 to 0.2% of patients with like severe hyponatremia. And the prognosis is mostly good. At least recently, we've known that in the last 25-year data that we have, the prognosis that most patients recover is good. And the only patients who do really poorly are patients who you correct like 20 or 25 or have like a variety of other risk factors. Now, understanding that there's a lot of publication bias, but publication bias goes in both ways. So it's kind of hard for me to tell you exactly, but I do think it points out that perhaps ODS is not as bad a disease as we imagine first. It's not uniformly fatal, but how bad is it? How many patients does it actually cause mortality and morbidity in? I don't think we truly know. And the other important point is, I think there's a lot of other risk factors for CPM, and it primarily occurs in non-hyponatremic states. And that's why alcoholism and malnutrition, all of these other risk factors, and perhaps some forms of cancer, they take precedence. So if I have to talk about correction rates, I will say that if you have a high-risk patient who has severe alcoholism, malnutrition, frailty, I think going beyond 20 would be a big mistake. Going beyond 15 is probably wrong. I highly doubt 6 versus 10 is going to make a difference. For example, if you take the same patient who developed ODS and one nephrologist had corrected at 6 and another nephrologist had corrected at 10, I highly doubt you can say that the nephrologist who corrected 10, was the one who's in the wrong. Meaning you just don't know if it made that big a difference in a patient who already had such big risk factors to begin with. My practice has traditionally been that in patients with these risk factors, I go very slow. I'm extremely slow, 4, 6. I will accept. If it goes to 8, I'm going to be humble and say that's okay. But my practice is to go extremely slow, and I use 3% saline and DDAVP. But let's take away these patients and take the large extent of other patients who come in, and this is maybe 3/4 of the patients who's all others. I don't really know if 6 versus 8 versus 10 versus 12 versus 15 makes a big difference. My practice is not to aim for a particular rate, meaning I think 10 is a reasonable rate to at least aim for, but I take a very non-lackadaisical approach, meaning I do want to correct it. Meaning if I see this patient, I want to start them on hypertonic saline to make an attempt at correction rather than say, I'm just going to wait for the next set, wait to see what happens, give DDAVP and see what happens. No, I really want to know what the cause of hyponatremia is, and I do want to correct it to get to a certain point and to get to a certain level, at least in the first 24 hours. Now, when you talk about correction, you have to talk about relowering, and I'm not sure there's enough data. There's some animal data, but there's not enough human data to suggest that relowering is very useful. I do think it's useful in a small subset, meaning if the starting NA is really low, which kind of indicates severity of disease in patients with these bad risk factors, or if the correction rate is high, which I say is like if it's more than 12, I almost try to correct it, bring it back a little bit, get it to below 10 at least. But in most of the others, let's say I'm aiming for 10, it goes 12 or 13, I almost never have to correct it because I think the risk of ODS is almost non-existent in patients who don't have these risk factors if we correct slightly higher versus less. So, my ardent wish for this field is that House of Stark and House of Targaryen form an alliance, move beyond taking sides, and engage in meaningful research and conversation to deepen our understanding of the problem. However, the cynic in me and the skeptic in me says that that'll never happen, and that we need new blood, new investigators in this field who are looking at it from a non-biased standpoint and are looking at all the evidence to see how best to put forth and what kind of studies we can be doing to better understand the problem. So I really want to thank Dr. Nigwekar. That's the end of my talk. Who always says, look at the data, let the data speak for itself. You don't have to build a story and look at the data. Look at the data and see how you can explain the data. And the Kidney Research Center for all the support. I also have to thank the Boston Celtics, yay, the 2023-2024 NBA champions. They finished the job on Monday, so put me in a good headspace for this talk. So thank you, and thanks to all of you for listening.
Thanks, Harish. That was a brilliant overview. It was really interesting to see the older data that I had vaguely heard about, but I had not actually, reviewed personally. So it's fantastic to see that. Dr. Noel.
Yeah, that was an excellent talk. I really like hearing these stories of where we get ourselves to now. I mean, I guess you almost painted a picture that a randomized trial is never going to happen, impossible. Outcomes are rare, recoveries may be better than we think. But is there something that we could study, like you said, meaningful research? Like what kind of a trial may be able to move this forward? I'm trying to think of something practical, or perhaps maybe something in the non-high risk people, because I think everyone in the high risk people are going to probably be very cautious or try to be as cautious as they can. But what about that other group? I don't know, between 120 and 130, no big risk factors. Do you think there's a reason for a trial?
I think if you look at, that's a great question. And when we look at high value care, I think that's where our money should go. If we were to do research, I think it should be those patients, the majority of patients who don't have these risk factors that we keep in the hospital for no reason. And I think if we can prove that, we don't have to be super, we don't have to like separate them a lot, but if we can prove that a correction rate of 6 versus a correction rate of 12 would save a day or two in the hospital, or have the same outcomes, that's a huge win for us, especially in the current healthcare system. And so I think that's a good thing to study, but also I want to point out that I don't think we truly understand our outcome. Meaning, I think that we know what CPM is. As I said, radiological or autopsy-proven CPM is black and white. But the whole controversy is over this big sort of like mess of a condition called ODS, which we call as a clinical syndrome. And we don't truly agree on what that is. If a patient has less strength in their arms and legs for a couple of days and then walks out of the hospital, is that still ODS? Is that still a bad outcome? Versus a patient who's wheelchair bound, is that a bad outcome? That seems like a bad outcome, right? So I think to truly understand that, I do think we have to do a prospective study where we take high-risk patients who correct fast and sort of see what happens neurologically, like really strict neurological, really well done, high quality neurological exams, as well as the imaging modalities that we have today, which are really good at detecting a lot of stuff. We need to see what happens to these patients, irrespective of how they look clinically. And I think only if we are able to do that in a certain subset of patients do we truly understand the spectrum of the disease that we're dealing with, to help us design a future study where we know what outcome we want to avoid. Because right now we just say ODS, but I don't think a single person understands ODS beyond the 2 phases of like quadriparesis, pseudobulbar palsy, but that's not the norm. That's extremely rare. Meaning, I asked all my colleagues if they've ever seen a case of ODS, and there's one person raising their hand that was like 6 years ago, 7 years ago. It's very rare to encounter such a case of ODS, but I'm not discounting the fact that there's been quite a bit of research going on that neurological sequelae is possible. I just think it's less severe, and I just don't think we understand it fully. And I do think we need to study it more.
Thank you. Yeah, hospitalization would be more of a target than ODS. Brendan.
Thanks. I really enjoyed the presentation and particularly enjoyed the historical overview. And what really struck me was kind of the shift in the 1980s and 1990s from CPM being a alcoholism malnutrition associated diagnosis to a hyponatremia overcorrection associated diagnosis. Now, one historical thing that also happened in that period of time is the not so much the introduction, but the increased prevalence of use of thiazide diuretics, especially very high potency ones like chlorothalidone, which was used in a lot of the initial trials in the 70s, 80s, 90s. And arguably, thiazides are a great way to cause intracellular malnutrition with the potassium and magnesium depletion. And obviously, all the studies do show hypokalemia as being a major risk factor for CPM, but for some reason, thiazides never kind of come out epidemiologically. And I'm wondering, I guess, 2 things. One is, are we just not looking closely enough in a lot of these epidemiologic studies for the association with thiazides? And then the second question is, in your approach at the end, where you indicated, the slow correction for malnutrition, alcoholism, should thiazide-induced hyponatremia also be in that slow correction arm?
That's a great question. If I believe the hypothesis that was, that CPM is an apoptotic process and an energy is very important, then I don't think it's just the thiazides. Meaning, I think it has to be the thiazides on something else. Meaning, thiazides are predominantly, and I don't know the data behind this, but not a lot of people with severe alcoholism are on thiazides, meaning it's not that common to see it. But malnutrition, sure, meaning a lot of cancer patients and a lot of other patients could have malnutrition and are on thiazides. I have to say, I don't know the answer to that. It just doesn't come out because I think that there's been no research on it for like 25 years. That would be my biggest sort of takeaway from it, that if at some point we sort of like stop looking at risk factors and how best to manage, subgroups of patients, and we just decided we'll focus on correction rates as a whole. And I think after 1990, there's hardly any papers other than meta-analysis or case series putting together older cases on any of this. So we don't really truly know what happens in these specific subgroups of patients. I think there's still a lot to study. Meaning, I think liver disease and alcoholism, I think is a sort of a separate subgroup to study. I think malnutrition, how you define it by, I think it's a separate group to study. Thiazide diuretics, I would say the same. But this all requires an actual sort of conclusion that, hey, there are other risk factors and we need to study them. So
exactly right. It's 9, but we can take one final question from the conference room.
Hi. The business about women, particularly younger menstruating women, and there's a phase when animal studies, I think, said that female hormones had something to do with the incidence in animals. Of course, at the time, I think that paper you presented of post-op hyponatremia in women, a lot of it was probably because gynecologists did hysterectomies, gave people D5W as post-op fluid. At this stage, do we think that sex has anything to do with it?
yeah, I think if you look at up to date, I think they still mention women as a high risk subgroup, and I do think just because of the body composition and the physiology of body compartments, I do think they're at slightly higher risk. But as you said, it comes down to practice, meaning this, 50% of women, and we don't really see a huge difference in the incidence of hyponatremia or the risk factors or the incidence of like ODS or CPM that's differentiated between males and females. So I don't think there's a huge difference in the outcomes there, but I do think there's slightly higher risk, but I don't think it's anything to like really particularly study. I think it's just you can induce hyponatremia a lot faster, easier in women. And that's why, like, if you give thiazide diuretics, women are more prone to hyponatremia than men are. And I think that's kind of the reason why, and nothing else. I don't think there's any hormonal effect or anything of that sort.
Fantastic. Thank you. There was one question in the chat, if you have time, asking about, is there any way to measure metabolic activity in the brain, high metabolic activity that might define the risk, like a PET or something? Going back to
I think
to basic science research, maybe.
Yeah, I think that's where we need to head. I think that's where, with all these new imaging modalities, at some point, I think CPM became a nephrology disease and not a neurological disease. I think that's where the switch swapped and neurologists stopped doing research and basically thinking that, hey, it's all the sodium, the nephrologists got this, they're smart people. But we never sort of involved the neurologists and the radiologists and be like, hey, you are seeing this in a ton of under conditions. How else can we sort of differentiate high risk, low risk? What's the severity of the signal you're seeing? I think there's a ton of work to be like sort of done in that. It's just that this condition is incredibly rare. So I think it's just very hard to like study. But I do think we need to like look at even if it's case reports or small case series, I do think we need more data on like, better imaging modalities and maybe things like metabolic uptake and things like that.
Fantastic.
Also, there's other imaging modalities that look at like sarcopenia, right? Like it's like how malnourished are you, the ratio of your like interstitial fluid to your bones and things like that. So we have some advanced imaging studies available to us now that we don't necessarily use in these patients, but maybe we should.
Yeah, exactly. On that note, thank you again, Dr. Seethapathy, for that brilliant overview. Hopefully, House Targaryen and Stark will join forces sometime in the future. This is, of course, for the people in the audience, this is the last rounds of this academic year. We'll start again just after Labor Day. So wait for that. And if any of our fellows want to apply for GlomCon, this is the person who will be reviewing your application. So aim there. Thanks again, Harish.
Of course. Thank you so much, everyone.